Good evening from Malaysia. Thank you to the chairperson for the kind introduction. Thank you to the organizing committee for the invitation to participate in this meeting. Good evening, ladies and gentlemen. I've been tasked to speak on fasting in chronic kidney disease. This is the agenda of my presentation: a brief introduction, epidemiology of Muslim and chronic kidney disease, effect of fasting in chronic kidney disease. Subsequently, I'll speak on recommendation for fasting in chronic kidney disease and take-home messages. Ramadan fasting, which is the fourth pillar of Islam, is compulsory after puberty. However, those who are ill or have underlying health condition can be religiously exempt. Fasting is considered an honored act. This makes even the sick who are exempted risk their life for a charitable deed. The fast of Ramadan is observed by abstaining from food and drink, including water, from sunrise to sunset. Fasting can last 12 to 14 hours on average, but also can last from 8 to 22 hours. 20 hours. The dates for Ramadan are based on a 12-month lunar calendar. Thus, Ramadan falls 11 days earlier annually. And over a 33 years period, it will pass through all 4 seasons, leading to shorter fast in the winter months and longer fast in the summer months. In tropical countries, the timing of fasting is relatively constant every year, between 12 to 14 hours. However, fasting during the summer month in the temperate region can be up to 20 hours. There are more than 2 billion Muslims globally. This constitutes a quarter of the global population. Most Muslims reside in the Asia-Pacific region, the Middle Eastern region, and Sub-Saharan African. This slide summarizes the world prevalence of chronic kidney disease. There are roughly 840 million people affected by CKD, which is roughly about 10 to 11% of the global populations. So there are roughly about 210 million Muslim patients with chronic kidney disease worldwide. This world map summarizes the prevalence of chronic kidney disease across all the major continents, ranging between 7.6% in Sub-Saharan African to about 10 to 11% elsewhere. So for the purpose of these presentations, we will look at the evidences in 3 patients group on the effect of fasting to their kidneys, as well as other adverse effects. They are the non-dialyzed CKD. This can be from CKD stage 1 to 5 non-dialysis, CKD stage 5 on dialysis, either on peritoneal dialysis or hemodialysis, and those who underwent kidney transplantation. The first group of patients is the non-dialyzed CKD. Almost 50 to 60% of chronic kidney disease are due to diabetes mellitus. And we know that progressive eGFR reduction leads to lower insulin requirement and oral hypoglycemic doses. So many concerns related to this group of patients are also related to diabetes-related complications, such as hypoglycemia, hyperglycemia, and diabetic ketoacidosis, which I will not cover in this presentation. The other concerns are related to the kidneys, which include dehydration leading to acute on chronic kidney disease, fluid overload due to excessive fluid intake during iftar, and electrolyte imbalance. So what is the effect of Ramadan fasting on GFR? There are basically no randomized controlled trial to examine this effect. All the studies are observational studies. Majority of these observational studies are conducted in the Middle Eastern countries where fasting duration is between 12 to 14 hours. As alluded to earlier, fasting duration in temperate region during summer can be up to 20 hours. So this finding cannot be applied to CKD patients in this region. Several studies indicate that they observe changes in eGFR during fasting. Some studies did not show the effect on eGFR during Ramadan fasting, which I will share in the next slide. The above 4 studies by Al-Mohana, Nasrullah, Barhid, and Bologlu suggested there was a reduction in eGFR or creatinine clearance, whereas Aldip and Bernier reported an improvement in eGFR. So these are some of the studies concluded that fasting can be safe and do not have much impact on GFR among CKD patients. So there are several studies which did not show any impact whatsoever. So the next one is on fasting among end-stage renal disease patients who are undergoing dialysis. We know hemodialysis is a hypercatabolic state, and dialysis patients usually have to adhere to a restricted diet of low potassium and low phosphate. While fasting, the difficulty imposed with dietary restriction in such patients can make it difficult to meet their nutritional requirement. There have been several published studies on hemodialysis population, which I have summarized in the blue table. Majority showed no significant adverse effects. However, electrolyte imbalance, higher interdialytic weight gain have been observed, and one study reported increased mortality during Ramadan. There has only been one study in peritoneal dialysis patient which reported no significant effect of fasting in peritoneal dialysis patient. Moving on to kidney transplant recipients, these are several small studies, small observational studies reported by several authors. It appears that fasting is safe in kidney transplant recipient. There have been no significant reduction in estimated GFR, except for one study reported increased risk of renal colic. So how do we manage these patients for Ramadan fasting? I'm going to touch a little bit this recommendation, which comes from the International Diabetes Federation, Diabetes and Ramadan Alliance. So the first recommendation is all individuals with type 1 and type 2 diabetes and CKD or with any other renal issues should discuss their intention to fast during Ramadan with diabetes and renal specialists at least 3 months prior to Ramadan and attend Ramadan-focused education. As alluded to earlier, Ramadan fasting may put CKD non-dialysis patients at higher risk of complication, especially those with stage 4 and 5. In stable CKD stage 3 patient, fasting is possible. However, some report did suggest abrupt loss of kidney function can occur, and these risks need to be counseled to the patients. The second recommendation is individual with diabetes and CKD stage 3 to 5 or on dialysis should be considered high risk, and fasting ought to be discouraged. So this slide summarizes on risk stratification of fasting among CKD patients. The low to moderate risk can be allowed to fast. This includes patients with stage 1 to 3 with stable kidney function and chronic kidney disease patients who are prone to urinary tract infection or stone formation. High-risk patients should not fast. These include patients with unstable CKD stage 1 to 3 and CKD patients with known electrolyte abnormalities, patients who are at risk of dehydration due to fluid restriction requirement or need for diuretics, and patients on ACE inhibitors, angiotensin receptor blockers, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. The very high-risk patient should not fast. This includes stage 4 to 5 non-dialysis patients, patient on all form of dialysis therapy, stage 3 to 5 CKD patient with a history of pre-existing cardiovascular disease, patient who are taking tolvaptan, and pregnant CKD patients. The last recommendation is what to do if the patient insists to continue fasting. This patient should be cautious and vigilant, and they should be aware that if their health deteriorates, they may need to discontinue fasting. They may need to break the fasting for medical reasons. Fluid drinking at night is advisable to stay well hydrated, but should not be excessive to the extent that it may lead to fluid overload. Patients should be taught to assess self-daily weight and examination for edema, and patients should avoid high contain potassium and phosphorus food. In cases who have an increase of serum creatinine by 30% from the baseline or a significant change in serum electrolyte levels, must be advised to break their fast. The frequency of creatinine, urea, and electrolyte assessment depends on the local recommendation and availability. Patients should be monitored 1 to 2 times weekly for change in body weight, breathlessness, anorexia, weakness, and edema. How about fasting among patients with CKD on dialysis? Dialysis end-stage renal disease dependent patient can perform fasting. However, it is highly recommended for them to not to fast. If they insist on fasting, they require regular monitoring and should be reviewed carefully on dialysis days. How about a kidney recommendation for fasting in kidney transplant recipient? Kidney transplant recipient who have a stable allograft function and taking their immunosuppressant should be able to fast. Regular follow-up before and after Ramadan is recommended. However, this patient needs to drink enough fluids and they need to take their immunosuppressive therapies during the non-fasting period. In my personal practice, I discourage fasting during the first year of transplantations, mainly due to the timing of immunosuppressant. Absorption of drug with narrow therapeutic index, such as tacrolimus and everolimus, as well as mycophenolate, is interfered by food. So these drugs need to be taken on empty stomach and eat food an hour later, or to be taken 2 hours following a meal. In Malaysia, our fasting is roughly about 13 to 13.5 hours. And I usually ask the patients to wake up at 4 o'clock in the morning for sahur, take immunosuppressant just before imsa of Fajar, which is about 5:50 to 6 o'clock in the morning, and take their immunosuppressant at breakfast with a small amount of water, which is about 13 hours later. Perform their Maghrib prayer and consume food an hour later. This is my take-home messages. Basically summarizes approach to Ramadan fasting for chronic kidney disease patients. First, they need to explore their wishes. We need to explore their wish to fast. If they do not wish to fast, which is allowed, we just continue the same management. If they wish to fast, re-stratify them as mentioned earlier. A patient with low to moderate risk can be allowed to fast. The high risk should be counseled for other alternative, whether they can fast during winter months or pay for fidya. If patient still chooses to fast, the following needs to be performed or considered. They need to be educated on risk and reinforce sick day rules. They need to be counseled on risk of fluid overload, electrolyte abnormalities, and nutritional requirement. We may need to make necessary changes to their medication, explore a possibility of once daily alternative or temporary cessation of medications such as tolvaptan. In some patients, we may need to alter their dialysis regime, and we may need to advise them to terminate fast if they become unwell, and the patient should consider a trial fast, for example, 1 month before Ramadan, to see whether they can manage it or not. With that, I thank you for your kind attention.